Good morning. My name's James Danger, and this is part one of two videos I'm making on translating andrology and embryology EQA performance into KPI tools for assessing individual laboratory staff's competency. So this is part one. I've already posted part two, which is the basis of a talk I'm giving in a couple of weeks. But this is the preamble for it, and basically starts with the same way. You look at three embryos, and you say this talk is about a common language in the laboratory. It's about every staff member describing these three blastocysts in the same way and how most KPI systems depend and require such uniformity. Otherwise, a KPI means it's a lot less. For instance, what is the percent A grade blastocysts? And if there's a lot of variation between people, how can that KPI be valuable? So if you're going to do a KPI looking at percent good quality embryos and have some definition, grade A, grade B, whatever, for AA, etc., you have to have some tool available to make sure that every staff member is assessing it the same way. But it's more than that. Every client has got a right to expect the same decisions to be made by all staff members. You don't want to come in to have an embryo transferred and you find that depending on who is in the laboratory, you may get different embryos. Now, I have created and operate an online EQA program at ferdaid.com since 2003. It's been going for 25 years and serviced thousands of scientists over the years that come and gone, various degrees of interest. But this talk is about how you can use such an EQA program such as FERDAID, but you may be able to use your own one depending on how the data comes out to monitor your clinic's competency in identifying accurately or consistently gametes and embryos. So I start here as an image. When you make a decision to grade an embryo, underlying that decision is the desire of some action you're going to take for it. It could be which embryo will you transfer first, so you're ranking it. Sometimes it's easy if there's only one or two. Clearly, this is the best. But if you have lots and lots of ones, sometimes this is where AI can give you a heads up about which one you may be better. But even if I look at this, you can see these are all blastocysts, but they're all quite different. And I'm sure everyone looking at this video will grade these things roughly the same, but there will be significant variation between the 4AA, 4AB, etc., etc. But other way you interpret an embryo can affect the system right through the whole quality management system. Which embryo would you biopsy? Which would you vitrify? Which would you discard? Which would you wait another day? How would you describe this embryo here? Is it a 4AA, 4AB, 4BA, 4BB? If I was doing a talk, I'd ask everyone to put their hands up, but maybe you may like to, at the completion of this video, just write a comment and add your view on whether you think the embryo is a 4AA, 4AB, 4BA, and 4BB. However, to make a decision on the fate of an embryo, you need to be able to describe it in a specific point in time. That description needs to be universal so that both you, other staff members in your clinic and clinics elsewhere, and the data system all need to see the same embryo or sperm at that particular time. Now, there's a lot of visual assessments in IVF, and my EQA program touches on most of these: sperm motility, morphology, concentration, immunobead binding, halosperm, vitality testing. But each of these embryos, the oocyte, pronuclear, cleavage blastocysts, either visually under the microscope or as a time lapse, still requires a considerable effort to make sure everyone is describing it the same way. And this also applies for the follicular scanning and endometrial scanning, which there's a huge variability, and that is not being assessed at all, in as far as I know, in any program. So you have all these studies being done looking at the endometrial thickness, done in a dark room by an ultrasound, and I'm sure they're very good, but a lot of nurses are also doing it, and you have no idea just what the variability is. Anyway, I will talk briefly about time automated systems a bit later on. But I just want to make a brief comment about the standards. There is a standard for sperm and there is a standard for embryos, but it's the implementation of these standards that's the issue. Everyone talks about WHO, and it's been a fantastic book. It has certainly created uniformity, but it's also created a huge burden in how you can try and define sperm. And the real problem with the WHO is that it's actually designed for looking at male fertility or infertility in the general community. The standards are all based on looking at samples about and whether that husband can get their partner pregnant in 6 or 12 months. It's not to do with IVF. And we've spent enormous amounts of publications trying to describe WHO standards and fertilization and pregnancy rates. But the standards for WHO, sorry, that is not actually for IVF. You need to remember it. There is a very good review on the on how you describe embryos. This is the most updated one. It's there's one done in 2014, I think. This is one done a couple of years ago, and it's a long book. It's a long article, but you may like to make sure that every new staff member sits and systematically reads it, maybe once a year. But there is some issue here which I'd like to take issue with, and that is in traditional medical adage is see one, do one, teach one, describes a three-tiered approach to training, observation, and supervised practice and instruction. And I think that applies to IVF as well, and I think it's wrong. So when you start in any laboratory, you may be given a sample, you have to do 200 estimations of sperm morphology, and if you're pretty close to the supervisor's sign-off, say you are now competent. Boom, you are competent. And for the rest of your working life, you are never really tested. But I actually disagree with that entirely. It's the same with embryos. You sit there and you show new staff members what this is a good bless, this is a poor one. You sit and explain it, and you get them to do a thing. But after a little while, 1 or 2 days, they're off working by themselves, putting the 4AA on the worksheet, right? And once you've deemed that embryologist is competent, you're ready to go back and do it. And in reality, what all laboratories should do, particularly teach with time lapse, is to run a video, sit around with all the staff members and get them to write down on a piece of paper what the grade of the embryo is, and to tell you what, you will be horrified. So this is about an issue about competency. We're once taught and deemed competent. It's been since I wrote QAP, and I firmly believe that's not the case. And people need to their views need to be assessed constantly. In reality, though, the decisions aren't really going to make a lot of difference. It may be whether you have sperm with IVF or ICSI, and I'll talk about that in a second, for embryos which are transferred first, frozen, biopsied, etc. However, no matter what happens, all cumulative live birth studies have shown, no matter what form of interaction, when you make an embryo, you put the back best and increasing the best one remaining all the time, the chance of having a live birth within 12 months is the same. Hardly any intervention works. The only thing that matters is the age of the woman. But I'd just like to come back and talk about standards, particularly what I said, how these standards have a vagueness and soft definitions about them that leads it difficult to interpret them. There's an arbitrary nature of these standards. And there's often a real lack of clinical relevance in some parameters, for instance, sperm morphology. If you look at these images of sperm, which are coming out of the WHO manual, which one of these are normal? Is this normal? Is this one normal? Is this one normal? You'd be surprised. If you go to FirtAid, I have a module in FirtAid where you can test yourself over and over again. And it's quite scary. Most people get about 75% right and about 25% wrong. And the problem is the standard really is quite good, except that there's a lot of variation about the shape of the mid piece and the roundness of the posterior part of the sperm head. And those subtleties create all the vision. Basically, the sperm morphology is decided by one person quite a few years ago, and it's only his opinion anyway. So, but if you actually have a person that judges them all wrong, it can have a real impact. So, for instance, if someone judges all sperm to have a really bad morphology, so they're assessing it really bad, what happens then is that every time that person does semen analysis, the report goes back to the doctor. The doctor says you have abnormal sperm, you have to do ICSI. For that time on, that person is committed to doing ICSI and spending thousands of dollars in extra every time they come through, when in fact the person may just be assessing morphology wrong relative to everybody else, right? Likewise, these 4 embryos, I know they're not particularly good, and they were deliberately chosen to be of poor quality. Each of these embryos have the potential for pregnancy, some higher, some lower. It matters, though, to the client, but will differ between clients. So you have 2 standards. You have a scientific standard and a standard that applies to clients, and they will put different values on it. Some people will say, only put this one, throw the others out because there's no chance of pregnancy. And other people will say, I don't care if it's horrible, put it back. I just, paid the money, I want the embryo. And so when you're making grades, particularly make decisions about discarding, etc., you have to remember that your decision and the client's may vary, and each client will be different, and that will differ over time. So the issue here is not about the standard and clinical application. It's about uniformity between staff to minimize the clinical decisions being dependent on staff's visual assessment of bias. And the last thing is Dave Mortimer always used to say, you never know how the data is going to be used. Embryos can move between clinics, but also publications can be based on quite data which is quite volatile. You might be able to show a significant difference between one treatment and another, and the number of good quality embryos. It could actually just be that one person grades embryos better than the other and happens to bias the results. It's got nothing to do with the treatment, it's just the person describing the embryo. I just need to go one more thing. A lot of people have actually, I know a lot of scientists no longer are interested in morphology. Many people think it's dodgy, and they are. They often, because how can there possibly be only 4% normal form? This is crazy. But in fact, something in morphology is actually a very good illustration of why you need to have good quality controlling standards. So I actually disagree that it's not of interest, because there's been a lot of publications that have tried and failed telling sperm morphology to ICSI outcomes. They're destined to fail because only good sperm is selected. But morphology is linked to DNA fragmentation, and fragmentation is linked to miscarriage and aneuploidy. So the correct estimation of DNA fragmentation, say in allosperm testing or in morphology, lies at the very heart of the current IVF preoccupation with euploid embryos. Now, once again, you never know how data is going to be used. And so we have an obligation, if we're publishing material, is that the staff who are doing the assessment have some form of auditing and quality control. Once again, it's got to do with definitions. This is the Dave Gardner's definition of blastocyst, while has stood the test of time. It's robust because it's fairly vague. I mean, there's only 3 grades of inner mass and only 3 grades of trophectoderm. But it makes it very hard to compare people because there's a lot of variability. And he would have been better, I think, to have had maybe 5 grades in both of these and force people to look at an embryo and actually make a very firm decision. And I think he could well have very quickly modified it. My point here is that a soft criteria leads to variability in diagnosis. I should actually say in Dave Gardner's defense that in fact his method is, because it's simple, everyone has applied it in a roughly the same way. But there's a lot of difference between 4AA and 4AB and 4BA. It's the subtlety is where the variability is. To make a decision on the fate of an embryo, you need to be able to describe it at a specific point in time, because the embryos are always developing. So that description you make needs to be universal, so that you, other staff elsewhere, and the data system all see the same embryo. I've said that before. But also standards can change. A really good example of this is pronuclear grading. So Lynn Scott, who was a really great embryologist, did a lot of work in pronuclear workers, died a couple of years ago, unfortunately. She's a great person. She developed a scoring system based on the size of the pronuclei and the number and distribution of the nuclear bodies, Z1 to Z4. And that has stood the test of time, although hardly anybody uses pronuclear grading. Most people now are only interested when the pronuclei start to fade as a time-lapse system. However, there's been a couple of publications in 2006 and 2004, which not so much look at not the distribution of the nuclear bodies, but the orientation of the pronuclei relative to the polar body and to the first cleavage. And the embryos where there's alignment between the pronuclear axis and the cleavage axis, these embryos have a far higher chance of forming a baby than one where the orientation is at 181. So you just should go back. You should go back. I've done a couple of other videos on this, which are worthwhile looking at the in-cell mass and zygote cleavage. I should have put the link up here. But if you're an embryologist, you would benefit from that. Just the acknowledgement about automation and IA. There are a few sperm analyzers that process some of the sperm parameters test very well. Some are based on real measurements, that is video movement of sperm, like Hamilton Thorne, but others view it just some form of light scatter. There's even one sperm motility analyzer that judges the morphology based purely and simply on the motility. Absolutely crazy. So, if you leave a sperm and motility starts to degrade, the morphology changes, even though it's the same sperm sample. I actually think that it's wrong, and it's just being used using an AI algorithm to convert motility into morphology. But the problem is none of them work at high and low limits, so you still have to be able to go back and assess it. With time-lapse systems, Some are really good, but they do consume a lot of staff time, even though they argue that it may not. In fact, I understand that in my experience is that you spend a lot more time looking at it. A person can sit and look at 4 or 5 embryos and within 30 seconds be able to very accurately assign the value of those. The machine takes a lot longer, but it does create huge amounts of data. They're expensive, and there are technical limitations on handling such embryos when they're inside a time-lapse system. But the automated time-lapse systems do cover the whole time culture period. But really, as we've always said, the critical decisions occur at very discrete times. Pronuclei you should look at them at between 15 and 18 hours, 68 to 72 hours for a day 3 cleavage. If you look at them in those times, the manual and the automatic systems are very good. The point, though, is if you're going to describe an embryo, you should be able to describe it both inside in a dish where you can roll it around and get a three-dimensional aspect, but also to make some informed decision on a two-dimensional image, even though it's oscillating up and down through the embryo. And currently, about 75% of all labs still do a hands-on process. There's not a huge movement of time-lapse and AI systems into labs, about 30%. But there's also a point here I'd like to make where the AI systems have always been done with in addition to manual, even though there's a desire to use the grading system to select embryos. But I thought this paper published just last month, looking at euploidy and comparing morphology and implantation. They split embryos into excellent, good, average, and poor. The excellent are the ones that are hatching. The goods are the ones that are hatching but poor quality, which doesn't strike me as being logical. And really good quality expandoblastus. Average quality, low B's of 3s and 4s, and poor is 2 to 1. But here's the thing. If you look at the distribution, this is the graph that I wanted to show you here. The graph for the blastus gradient, 4% are hatching, 25% are fully expanded, 25% have developed but not expanded, and almost 50% are rubbish. If you do a euploid test of the embryos, only about in this particular lab, 30% are euploid, 62% are aneuploidy, and 4% mosaic. Different PG labs will vary the amount of mosaicism they're reporting, and that has an impact on the number of euploid and aneuploid. But in reality, 2/3 of all the embryos you make are not normal euploid embryos. But when you look at the embryo quality, look at this, 60% of all excellent and 55% of all really good are euploid. So when you just look at an embryo and you say it's a 4AA, you've got a 1 in 2 chance, almost 1 in 3, 2 chances in 3 of saying that's euploid. And consequently, when you put the best embryos back, you're nearly always putting back euploid embryos. And the only thing I'm a bit worried about this paper is I don't quite actually believe this. That wouldn't have been my experience. The implantation rate for excellent embryos is almost 60%, but for poor embryos, which are 2AAs, they still reckon you can get a 40% implantation rate. I suspect by allowing them to go to day 6 or day 7. But I'd last ask the question, how good are you at describing a 2AB? It's a difficult grading system to do. Also, you can get caught up with this. This is a paper that came out a couple of years ago from some Indian authors. Once again, using a very simple system and just grading embryos AA, BB, etc. And the bottom line is that the inner cell mass is the more important one than trophectoderm. So even though most people look at the trophectoderm in grading embryos, it's the inner cell mass which is the real key to live births. And I suspect going forward, there will be revised standards on how you describe an inner cell mass, because the inner cell mass is both the inner cell mass plus the trophectoderm that overlies it. This is the part of the embryo that implants. And going forward, there'll be far more work looking at the polar trophectoderm and the inner cell mass and their relationship. And it's a number of cells in the inner cell mass that's important. So there will be a new standard for ICM coming out. I'm sure there should be anyway. But how can you assess the staff's competency as a KPI process? Well, currently most people do technical ones, like, for instance, the number of eggs you collect per pickup, or the exercise rate, or the survival after biopsy or freezing. But most people, and I've done this for 30 years, 40 years, look at the pregnancy rate per transfer for all the doctors and embryologists. And I used to do a thing where I compared doctors and embryologists, and the scary thing was that even though there was differences between doctors and embryologists, there was a huge difference in combination. We forget sometimes that a transfer, there are two people involved. There's the doctor placing the catheter and the embryologist injecting the embryo into the uterine cavity. But not a lot of people would look at pregnancy rate, for, say, for single embryo euploid embryos, and far fewer would look at set euploid embryos for women under 35. But if you want to compare differences between pregnancy rates, this is the KPI you should be using. But you can go back and look at your QA program and look at as a clinic, how many of your submissions are more than one standard deviation from a group mean in different schemes. But you can also go to individuals and look at how many outliers there are more than one standard deviation from the mean grading system. But you need to be able to translate 4AA into a numeric thing to do that. And if I've done that, it's one of the things I've done in my EQA program, where most of the morphologies are all numeric numbers, but all the embryology are option-based. And so I've developed over time various algorithms convert all the different options for, say, blastocysts into a numeric thing, which I can then do mean standard deviations and then deviations of individual embryologists from that. I know it's very difficult and time consuming to do that internally in your own lab, but if you look at your EQA program and ask the question whether you can get the data out of it to give you confidence that your staff are all performing the embryo or gamete and embryo assessments the same way. And just to a sneak preview, I spent part 2 of this video, which is already online, describing exactly how this works. But the EQA program, these are the different schemes: motility, morphology, concentration, ASOB's halosperm vitality, and pronuclear fragmentation, early cleavage, late cleavage, oocytes. I run some schemes where you're ranked, 1 to 5 embryos, 1 to top. But I also run endometrial follicle, which I think is rather clever what I've done there. But you have to go to part 2 of my video system to see how it works. But from that, you enroll in a scheme, you enroll the staff, and then each staff every month spend 10 minutes or 20 minutes or 30 minutes just looking at the images and answering the questions and getting their scores. And then you can compile from each individual staff members your clinic's performance relative to everybody else. So first, the EQA program part of it is you can demonstrate that your systems are things. So these are basically along with above and standard deviations above and below the mean. Blue is good, yellow is not good, red is bad, and black is disaster. So this lab is actually doing pretty good. Although notice here that morphology, this lab, which is, I think this has about 5 laboratories in it, about 30, 40 staff. By and large, the whole laboratory is actually reporting morphology on the high side of the normal range for the WHO standard. And so if you go to this video, so I've cut the video in half just so you can, otherwise you'll fall asleep, it's just too long. But you might like to go and look at that. But I'd just like to finish up the last couple of slides. Doesn't make any difference anyway. Well, most staff can tell the best of the worst, and if you hurry, you're probably going to get it right most of the time. And anyway, if you don't get it right the first time, you get it on FET. But really, it really only affects the first embryo transfer, because nearly all cumulative pregnancy studies, no matter what the technology is, IVF, NICSI, day 3, day 5, plus or minus PGT-A, the cumulative rates are nearly all the same. The only delimiter, the only real delimiter in IVF is the age of the woman. That is all. There are some other parameters which I think are really important, particularly miscarriage. So PGT-A does seem to reduce the miscarriage rate by 50% from about 20% down to 10. And I'm not entirely sure it's worth all the effort and cost to do that. But if you have IVF, you paid the money, you fall pregnant and miscarry, that is the worst case scenario. And I have a lot of empathy for doing PGT in everyone. It's purely and simply to reduce the miscarriages. But that is if 30% of people or 40% fall pregnant, and it's about 5% of patients coming through. That's a lot of people. So, but even poor embryos will give pregnancy, just not as many, and it just make my time more transfer. But on the other hand, if you are very consistent in assessing embryos, and I said if you're really good at and uniform in selecting embryos, you're more likely putting back euploid embryos, which means that there will be less chance of miscarriage and shorter time to first pregnancy. But if you have a lot of poor quality system where people are grading embryos and some of them are grading poor embryos better than they should be, then you have a lot of poor quality embryos clogging up your system, which involves a lot of space and auditing and risk. And really, there's little point in them being there. But also, there may be some embryos that are being discarded, which otherwise would not have. And this is a really difficult one because I know there's one case I know where the embryos were such poor quality, I actually did not want to do the transfer. But the doctor and the client said, I'll put them back anyway, Jim. It's just this is their last go. I put them back. And you know what? 30 years experience meant nothing because this lady had twins from two absolutely crappy embryos. Talk about being humiliated. But I learned a lesson there. But notwithstanding these individual rare cases that sort of tend to put you off your stroke, everyone describing embryos the same way. There should be a universal language in how you describe gametes between staff, between labs and clinics, and over time, and also for research, but also for KPIs and quality control. There's a movement towards using AI, and I like this paper that came out just last year, where they used AI to predict the implantation rate of the embryos people are putting back against the actual observed case. And I thought this was very clever, and I think it's got a lot of potential where you can demonstrate that different doctors have different outcomes um, in contradiction to what you would have expected based on embryo quality. I think it's very clever. But if you're going to provide your KPIs, you can use them for your staff performance. You use same thing for clinician embryologists. But I think I'm getting off the track here. I think basically to recognise that you can use AI as a very clever way to do quality control on your staff. And just lastly, utilising time lapse. I think you can incorporate time lapse into it. So you're not actually doing not manual scoring, but you can use it in terms of this average score of the embryos put back. And for instance, time of fading, time to blastocyst. And you can do that for each individual staff member rather than doing their assessment. You can look at their performance, but that's far more complicated and requires a very robust database system, almost impossible to do manually. And the last thing I just need to say about time-lapse systems is they're not necessarily transferable. You can see these are three that were published just recently, looking at the differences. And the difference between pregnant and not pregnant is very small, so we're not really quite sure what they're describing. But the numbers are quite small, but they're different between groups. I think I just want to finish by saying that the view of manual grading aimed to be consistent between staff, consistent between manual and time-lapse images, aims to ensure all clients get the same embryo. The aim is that the descriptions are uniform and allows decisions on each embryo to be consistent based on the uniformity of description. It allows all client workup and review to be the same, so you don't want people coming for you ICSI based on bad andrology tests. But it also, when you think about it, it also allows your KPI data to be collected in a meaningful way, allows material to be published. But really, it's a universal language. When we say it's 4AA, everyone knows what it is. Most people only use the accreditation systems, the EQA system for accreditation, not as a quality and training exercise. Yet gamete and embryo grading are the very core of IVF. Some clinics that have used QAP online have found as a supervising tool it was great, but the laboratory staff often argue it's time consuming and burdensome. The key, I think, is to engage staff in why they made decisions and to prompt or to promote and both an individual and a clinic desire for all staff to make the same decisions. Staff skills do drift over time as their experience changes. But the important thing, really, when I was writing this talk, I've really come to think about this particular issue. If you say have a KPI, such as with percent good quality blastocysts, you all have to be describing the same good quality blastocysts. No point having a KPI that doesn't make sense. Okay, I'd like to finish there. I know I talk too much. My name's James Stanger, embryologist. I'm 50 years experience. These videos are my photo channel, and my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor and maybe help in understanding the advice you receive. If you like what I'm doing, click Third Aid and click like and tell other people how good this system is. I have to acknowledge Third Aid, as I've said in my talk, it's a site I've written for providing online EQA for training for embryologists. And at that point, I think I'll say thank you and goodbye. I know IVF is a personal journey that involves the actions of many techniques, staff, and ideas. It's important to understand all of them. So, and at that point, I think I'll say goodbye.